Welcome back to Sculpting the Soul, where we explore the art and science of transformative plastic surgery with the renowned plastic and reconstructive surgeon, Dr. Ram Kalus. We have an exciting and insightful discussion in today's episode, as always. Today, we will be delving into the complex subject of immediate breast reconstruction and the specific skill set that is required to achieve the simultaneous surgical removal of a breast cancer while retaining a symmetrical and natural appearing breast. So, Dr. Ram Kalus, welcome back and glad to have you on as always.
Glad to be here. Thank you, Neil.
Of course. So we are going to jump right into it. Dr. Kalus, let's just start with the first question right off the bat about how serious this can get. Can you start by explaining the unique skills that are required for performing simultaneous breast cancer removal and reconstruction?
Sure, Neil. So, medicine is quite complex these days, and it's divided into many specialists and specialties. And breast cancer care actually has a team of specialists associated with it. And most of your listeners are going to be aware of the fact that there's a breast surgeon that is responsible for the surgical removal of the cancer, whether it's a partial removal of the tumor alone, which is a lumpectomy, or a removal of the breast in its entirety, which is a mastectomy. And then the other member of the team that we're obviously going to be discussing today is myself, the plastic surgeon, who is charged with making sure that we can retain a symmetrical breast shape for the patient, and we'll get into more of the details about what that involves. But what I really want your listeners to know is that with rare exceptions today, the surgical removal of the tumor is done at the same time under one anesthetic as one operation with the breast reconstruction. And a lot of patients and listeners think that if you just have the lumpectomy, if you just have the tumor removed, you actually don't need the plastic surgeon involved. And that's not always the case, because depending on the size of the tumor and the location of the tumor, there's a whole other terminology called oncoplastic plastic surgery, which means, or an oncoplastic reconstruction, which means that the plastic surgeon needs to reconstruct the breast in a way that the defect created by the removal of the tumor, but still with preserving most of the breast, that defect is corrected, is addressed correctly by the plastic surgeon. And that involves a very specific skill set that respects blood supply and really careful surgical planning that is tightly coordinated between the plastic surgeon and the breast surgeon simultaneously. So most of the time we're in the operating room at the same time at the start of the case and throughout the case specifically.
Sure. So, you talked about this being a very specific type of surgery. So let's talk a little bit more about that. What inspired you to specialize in this particular type of surgery, and talk a little bit more about your experience in this area as well.
Right. So I think, in many cases, it's a bit serendipitous. What that means is that where you start practicing, or where I started practicing at the University of South Carolina in Columbia, and then relocated my practice to Charleston and Mount Pleasant, it just basically turns out that wherever there's a need, that is the way our skill set develops. And both in Columbia and in Charleston, I was very heavily involved because there was a need for plastic surgery in the setting of the multidisciplinary breast cancer team that I alluded to a few minutes ago. So that involves, of course, the breast surgeon, the plastic surgeon, but it also involves the oncologist. That's the medical oncologist who may be deciding whether or not chemotherapy is involved. It involves the radiation oncologist that will make a determination as to whether or not radiation is involved. And those are two actually different oncologic specialties, radiation versus medical. And then we have, of course, social workers involved and psychologists involved. breast navigators who are nurses. We have geneticists involved because genetics can very much impact on the surgical decision making. If the patient has a genetic mutation such as BRCA1 or BRCA2, that could put her at a much higher risk of future recurrent breast cancer, and that might make her decision making along with her team that would influence the decision making as to what surgical procedures she should undergo. Anything from a limited breast conservation surgery such as a lumpectomy all the way to bilateral mastectomy, sometimes a prophylactic mastectomy on the opposite breast where there may not be cancer at this point in time, but there might be a high risk for it in the future.
Sure. So I think you just touched on it a little bit. I want to go into more detail about it, about the typical process a patient undergoes when preparing for this dual procedure. So can you just walk us through that?
Sure. So typically the journey of a patient with breast cancer begins at the time of diagnosis, which will almost always occur with a mammogram or an ultrasound by the radiologist. They might see a suspicious lesion on the mammogram, and that would in turn force the recommendation, or I should say bring the recommendation of a biopsy. If a needle biopsy, which is almost always the way it's done under local anesthesia in the radiology suite, if a biopsy comes back showing that there is a cancer in the breast, the next specialist that patient will be referred to almost always is the breast surgeon. And the breast surgeon will pull together the information that we have from the mammogram. It might be an ultrasound, it might be an MRI as additional radiologic studies, along with the pathology report to determine what the next surgical step would be. And if that next surgical step includes the consideration of a large lumpectomy or a mastectomy, then the breast surgeon will invariably refer the patient to us as the plastic surgeon to begin coordinating the surgical plan.
Sure. So it would always be best if everything went smoothly and swimmingly, but obviously in the medical field that's not always necessarily the case. So what are some of the challenges and difficulties that you face when you're addressing both oncological and aesthetic concerns in one surgery?
Well, the number one consideration is always curing the patient of cancer and making sure that she has a nice, long, healthy life, which is what we wish for all of our patients. So the medical, health, wellness considerations are number one. The aesthetic considerations of dealing with the reconstructive options and making sure that we have done our utmost to achieve a pretty and symmetrical breast that is the right size and shape for the patient, that is very high on the list, but it's definitely number two. And fortunately, in 2024, we have the ability to address both of those without discounting the second aesthetic consideration. And historically, it used to be thought of as kind of frivolous and not really medically necessary. But I think we've come a long way, Neil, in understanding that wellness doesn't only involve curing cancer, but if we cured a cancer and left a patient very disfigured, that could have tremendous emotional and psychological implications. Because if she is feeling despondent and low about her appearance, that can impact her self-esteem. It can impact her relationship with her partner. And if it's a younger patient with young kids, it can definitely affect how good a mother she's going to be to her kids. If this puts her in a bad emotional state because she's no longer feeling good about herself because of her body image having been so negatively impacted, that can have tremendous ramifications. So at first glance, one can think about this as just sort of, cosmetic and maybe frivolous or not that important. But as you give it a little bit of thought and dive into it a little bit further, you realize that, our goal with plastic surgery is the psychological well-being of our patient. And even though we're not necessarily reconstructing a functioning mammary gland, a lactating breast. The function of a breast is not only just to breastfeed, it's also to make a woman feel good about herself.
So how do you work with your patients to set realistic expectations regarding the outcomes of both the cancer removal and the reconstruction?
That's a great question, Neil. So realistic expectations is something that we always strive for, regardless of what plastic surgery procedure we're considering for a patient. And it is critical to make a patient understand that while we are striving to achieve the prettiest, most symmetrical breast that is both the size and shape that the patient desires, that being our goal, it's not always necessarily being realized. And so realistic expectations are set by us by a very frank and honest and transparent discussion about what can happen when things go well, exactly according to plan, and what might happen if there are complications. And complications aren't necessarily just related to the actual operation going as planned or not, but it can be an aesthetic problem that relates to post-surgical changes such as radiation, weight fluctuations that can occur with post-surgical oncologic treatments such as radiation and chemotherapy. So there's a lot that is involved in ultimately affecting the appearance of one or both breasts.
Sure. So, and we just talked about it a minute ago, but how important is it? Can you walk us through in a little bit more detail just exactly how crucial the emotional support aspect for patients dealing with breast cancer is?
Well, I really think, Neil, that this is the essence of what we're discussing when we talk about breast reconstruction. Most of your listeners are going to know that you don't need a plastic surgeon to cure breast cancer. You need a plastic surgeon to reconstruct the breast and hopefully by virtue of that restore the patient's wellness and well-being and emotional and psychological wellness. And that is what we're discussing here. And breast reconstruction is really an operation that ultimately is targeted to address the patient's emotional well-being. That's its essential purpose. I won't call it its sole purpose because we're obviously restoring a symmetry to the body, and that has both functional and aesthetic components to it. Functional in terms of being able to wear clothing, normal clothing, wear a bra or a bathing suit that fits well, but the psychological aspect of all of that is intimately interwoven with the physical attributes of the surgical outcome of breast reconstruction.
Sure. So there are always misconceptions about everything in the medical world. What are some of the common misconceptions that patients might have about breast reconstruction surgery after cancer treatment?
So that's a very important question. And the most important thing for our listeners to realize, which I'm sure they do, is that just as women come in all sizes and shapes, so do women's breasts come in all sizes and shapes. And one of the challenges for us is when the breast is particularly large or particularly droopy, because a droopy breast means that there's more skin than really desirable or necessary for the breast volume. That's why the breast is saggier or droopier. That is a very difficult situation to address without addressing the lift component of the breast, because every woman that we encounter in our office obviously wants the prettiest possible pair of breasts when all is said and done. And so the challenge is a successful operation that is carefully planned and designed based on respecting the blood supply of the breast skin and the skin of the nipple and areola. And a lot of women don't know that the breast skin and nipple can oftentimes be preserved with a perfectly adequate and appropriate treatment of breast cancer today in 2024. And many of the procedures that we do accomplish either a lumpectomy where we can save the breast, the nipple, areola, or a mastectomy where we can even save the nipple and areola. So the old images in medical textbooks of significant disfigurement with a big scar across the chest and the absence of the breast, that should be a rare phenomenon in 2024, and thankfully it actually is.
That's definitely reassuring to hear. That's definitely reassuring. Can you share a particularly memorable patient story that you think highlights the impact of this type of surgery on someone's overall life?
Gosh, I think honestly, Neil, almost every patient that I encounter, almost every breast cancer patient that I encounter is memorable because each has her own story, her unique family situation, the way she discovered her cancer, the impact of the diagnosis on her life, whether she's 30 or 50 or 70. Everybody has a unique story. And obviously, it can be that much more impactful when you add the layers of small children, or perhaps I just had a patient recently that I remember quite well. She had been single. She'd been involved in a very serious relationship. She was planning to get married. She did not yet have children, and she faced the diagnosis. And so at every stage of a woman's life, this is impactful, whether you are single and dating or not, whether you're married with small children, married as an empty nester and your children just left the house. Our self-image and our well-being is not age-dependent or life stage dependent. In other words, our self-image and the way we care about ourselves and the way we look and the way we feel about ourselves, as far as I'm concerned, ends either when we're dead or when we're no longer competent. And, if you think about a demented patient, in a nursing home, I'm guessing that patient isn't thinking too much about their self-image. But most of the rest of us are at every stage of life, from childhood and adolescence all the way up. And so this is certainly true for our female patients facing a diagnosis of breast cancer.
Sure. So I want to go back for a second to something that we talked about a few minutes ago, and that's evolution, because there's always evolution in the medical world. Things do evolve in terms of medicine and in terms of best practices. So can you share a little bit more specifically about how the field of breast reconstruction specifically has evolved over the years, and what advancements are you most looking forward to and most excited about?
Well, it's a great question, and I would tell you that breast reconstruction has been literally transformed in the last 15 years. The way we're doing breast reconstruction in 2024 is completely different from the way we were doing it in 2004, 20 years ago. Completely different. And we can get into the technical nitty-gritty details, but I can tell you that in my own practice, which is somewhat unique, we are almost always able to reconstruct the breast in its entirety at the same time that the mastectomy is being performed. I literally start the operation with my breast surgeon, and while the breast surgeon has completed, if it's a bilateral case, for example, while the breast surgeon has completed one side mastectomy, we are already beginning to reconstruct that breast while he or she is moving on to the other side to perform the contralateral mastectomy. And so we're coordinating our efforts in order to reduce anesthesia time, and the tried and true gold standard of breast reconstruction historically was putting in a tissue expander, which is a first stage type of implant which needs to be inflated over the course of several weeks to months in the office with a weekly or every other week visit, where a small needle is used to inject some saline, salt water, and slowly this expander is effectively a balloon that slowly stretches the skin out, just as a woman's tummy is going to stretch out over 9 months when she has a pregnancy. So we're doing the same thing over the course of a few weeks to a few months with the breast skin that was left behind after the breast was removed. The good news is that in 2024, in my own practice, probably less than 5% of the time am I actually going to be using a tissue expander. Instead, I will be using the final implant that the patient and I carefully reviewed and planned on in the office with regard to what size she'd like to be, what size would fit into her breast and into her chest, and getting that operation done in one operation. And there's, again, we spoke a few minutes ago about blood supply. That is the critical element in determining whether or not we can succeed in accomplishing our goal. And we always tell our breast cancer patients who are going to have an implant-based reconstruction that if the blood supply is not adequate after the mastectomy has been completed, and we have special devices to assess blood supply of the skin and of the nipple, if that blood supply is deemed inadequate to support putting in that replacement implant, the final implant of the same size as her native breast, then we may have to resort to the tissue expander where there's less tension on the skin. But as I mentioned a moment ago, I'm finding myself needing to do that less than 5% of the time these days.
That's good. That's good to know. Definitely want to keep the risks to a minimum, as we're going to get into in a second. There are obviously always risks involved, but I think it's pretty clear from the work that you've done that the rewards of having such a surgery after being diagnosed with breast cancer far outweigh those risks. So I wanted to kind of close the show by asking you to give your best advice to someone who is currently facing a breast cancer diagnosis. They have all kinds of options. Their minds are whirlwinds right now. That diagnosis just hit, and it's very potentially scary. So what advice do you have to give them?
Well, it's very scary. We all fear the big C. Cancer is a scary diagnosis because even if we step away from breast for a moment, even though that's the subject of today's conversation, any cancer is scary because everybody's fearful of a premature death and suffering along the way, by the way. But we fear not outliving our lives. We fear not outliving our children. Or I should say, living to see our children grow, etc., graduate high school, and so on. So cancer is a very scary diagnosis, regardless of the age of the patient, and that's certainly true for our younger patients. And sadly, we are seeing breast cancer at a younger and younger age. I've seen and cared for patients in their 20s with breast cancer. It is not uncommon to see women in their 30s, certainly in their 40s and 50s being the most common. So the first thing I would say to any patient is to be reassured by the fact that breast cancer today is highly curable. And that is not a statement that we can make across the board for every patient because every patient and every cancer is unique. But early detection is the number one goal for curing breast cancer. And early detection means keeping up with recommendations from the American Cancer Society with regard to the scheduling of mammograms annually, starting at age 40. That age cutoff has changed in the last few years. It was pushed out to 50, and now it's come back to 40. The 40 is not a hard and fast rule. If there's a very strong family history of breast cancer in a woman whose mother or grandmother or first cousins or sisters had breast cancer and she's 30, she might follow recommendations for ultrasounds a lot sooner, maybe mammograms sooner. And this is something she needs to discuss with her family doctor and her OBGYN in order to determine what the exact protocol as far as surveillance and early detection would be for her. But for the average woman, it would be starting at age 40 with annual mammograms. If the diagnosis comes back cancer, the first thing that I want any patient to realize is, number one, it's highly curable, and number two, If she fears disfigurement, that is rarely a fear that will be realized in 2024. We have remarkable advances in our techniques, both using breast implants and using the patient's own tissue, which can avoid the use of an implant, like using if there's an extra tummy roll or if there's some extra thigh tissue. And we didn't get into this whole conversation today, but there are many, many options for breast reconstruction. And I would try to leave all of our patients with an optimistic note that breast cancer today is highly curable, and the treatment for breast cancer with regard to the surgical considerations are many with regard to achieving a very beautiful and symmetrical breast reconstruction that the patient can feel just as good about as before she was diagnosed.
Well, that's definitely reassuring to hear, because there's obviously always some type of risk involved, but the benefits obviously clearly outweigh those risks in this situation. And like you said, they're very, very curable forms of cancer that you're dealing with. So we fear, obviously, like you said, we fear a premature death. We fear the pain and the suffering we're going to go through, but there is a cure, and you are the one who handles that, obviously, as an esteemed plastic surgeon, Dr. Kalus. We definitely want to thank you for your time today. Where can people find more of you on social media?
So our website is drkalus.com, and we would be happy to answer any and all questions with regard to email inquiries. There's a contact sheet over there, and of course, they can contact the office if they want to schedule an appointment.
Awesome. Well, Dr. Kalus, obviously a very heavy subject matter today, but it's always good to know that we have an esteemed professional like yourself here to help people with such a frightening situation. So thank you, everyone, for joining us today on Sculpting the Soul. And remember, beauty is not just about looks. It is about confidence and feeling your very best. So until next time, be sure to embrace your journey and stay true to yourself. Dr. Kalus, thank you.
Thank you very much, Neil.